Good evening, everyone, and welcome to Wednesday Wellness. Wednesday Wellness is a free live educational series presented by Trinity Health, and we are thrilled that you are joining us this evening as we discuss what every joint pain sufferer should know. Before we get started, we would like to share a few housekeeping notes. Your cameras and microphones have been turned off to ensure a smooth experience. If you have questions during the presentation, please use the Q&A chat feature at the bottom of your screen. The questions will be addressed at the end of the presentation. Lastly, today's webinar is being recorded and a link to the video will be sent to your email in the next couple of days. Without further ado, I am pleased to introduce tonight's presenter, Dr. Jeff Cross, an orthopedic surgeon with Trinity Health Medical Group.
There we go. I think I have myself unmuted now. Hello, everyone. I'm Dr. Cross. I'm one of the orthopedic surgeons here at Trinity Health in West Michigan. And tonight we're going to talk a little bit about knee arthritis. Although some people may have hip arthritis as well, a lot of the things that we're going to be talking about are somewhat applicable to hip arthritis too. Like she mentioned, if you have any questions, please put them in the Q&A. We'll try to get to them at the end of the presentation. I'll leave plenty of time to answer questions. If there are any additional questions after that, we'll try to get back to you on those by email or give you a phone call. So a little bit about me. My name is Jeff Cross, like I mentioned. I'm an orthopedic surgeon here at Trinity Health, both downtown and in Byron Center. Let's see, I'm originally from Bloomfield Hills on the other side of the state. I did my college undergrad years at Michigan State University. I thought I'd find a few more Spartans here on the west side of the state, but apparently not so much. I did my medical school at Beaumont Hospital back home on the east side of the state. And during that time, I actually rotated here as a medical student at St. Mary's. I was very impressed with how the hospital ran, seemed to have a very good patient-centered culture. The orthopedic surgeons that I worked with here were very focused on giving good care, and they all got along very well. So that was a very important experience to me, is what made me ultimately come back and take a job here eventually. After my medical school, I went down to Toledo to do my residency. I got very good training down there under Dr. Ibrahim. And during that time, I also pursued some of my interest in teaching and got a master's in medical education from Johns Hopkins. And finally went out to Boston and completed my fellowship in hip and knee replacement at Brigham and Women's Hospital as part of Harvard. A couple personal things about me. I'm a big woodworker, and that's sort of how I got into orthopedics in the first place. It's a picture of me and my dog Hobbs not too long ago building our shed in the backyard. Like I mentioned, I'm also very passionate about teaching. There's a picture of me here very enthusiastically teaching some medical students down in Toledo. This is a very important part of my practice. The residents and the medical students really keep me on my toes, and it's important for me to know as much as I can so that I can pass that knowledge on to them. And finally, some of you may have been in the Wednesday Wellness with Dr. Steelman about hip arthritis last year. Dr. Steelman and I have known each other since freshman year of college when we lived in the dorms together. We're very close friends and very happy to be practicing here with another very good surgeon. So tonight's plan is to learn a little bit more about arthritis, specifically knee arthritis. We'll be talking about what it is, what your treatment options are, and I would like everyone to leave with a better understanding of what that means and try to come up with a plan for your pain. So what is knee arthritis? Well, there's many different names for it. The most common name is osteoarthritis, but you may have also heard of rheumatoid arthritis or other things that lead to arthritis, like avascular necrosis, post-traumatic arthritis, infectious arthritis. It can be very confusing, but all of them refer to the same thing, which is just arthritis. Now, when we look at the knee joint, both the shin bone and the thigh bone, the femur and the tibia, have cartilage on the end of it. The cartilage is the smooth stuff that allows the bones to glide on each other rather than grinding. Over time, that cartilage wears thin, and the wearing out of that cartilage is called arthritis. You can see the picture on the left. There's a healthy knee joint with that nice shiny white cartilage and a big blue meniscus. And on the right, you have a diseased knee or an arthritic knee where that cartilage is worn out. There's pits in the cartilage and cracks, that meniscus is worn out, and eventually people are what we call bone on bone. Typically, people will have pain on the inside part of their knee, and they'll start to walk with a bit of a limp, maybe rely on a cane or a walker. Now, nobody wants to be told that they have arthritis. These are the things that I hear the most commonly when I start talking to people about it. I'm too young. My knee never hurt before this. It doesn't hurt all the time. And how do you know this isn't my meniscus that's causing those problems? So I'll talk a little bit about how we make that determination that you have arthritis first. So how do we know? Well, anytime a patient comes to my office, the most important thing is for me to listen very carefully to your story. I like to hear everything that's going on with you, about how long your pain has been happening, where it is. I think some of the finer points of your story really help us determine whether or not this is arthritis or something else. I also examine all of my patients very closely. There's kind of telltale signs in an exam that somebody is having pain from arthritis. Your x-rays are probably the most important thing. You can see on the left here, there is a normal knee joint, meaning there's space between the femur and the tibia, and that space represents cartilage. The cartilage is the good stuff. On the right, you can see an x-ray of a knee with arthritis, and that knee no longer has any space. All of that cartilage has been worn away. You can also see some other changes in the bone. And what I want to bring everyone's attention to are the little bone spurs on the sides of the joint. Those bone spurs are not causing any problems. Those are just a symptom of arthritis. Everyone with arthritis will get bone spurs. They don't need to be removed or taken off. They are just a sign of arthritis. Now, sometimes if your exam, your history, and your x-rays don't quite give us a perfect picture of what's going on, we may order an MRI so we can get a better idea and make sure that we have the right diagnosis. Sometimes injections help us with that decision-making process as well, and we'll talk a little bit about that later. Because there are some other things that can cause knee pain that aren't necessarily arthritis. Things like bursitis or tendinitis of the tendons or the bursa sacs around the knee. Sometimes a pinched nerve in your back can give you pain that starts in your knee and goes down your leg to your toes. Usually there will be some numbness and tingling or weakness with that. And finally, even just a sprain or a strain of the ligaments around the knee can cause pain. Sometimes these things all happen and somebody has arthritis, but maybe it's the other thing that's causing most of their pain, not the arthritis, and we need to make sure that we're treating the right thing. So, assuming that we've done all of those things and we've figured out that you have arthritis, now what can we do? Well, the first thing everyone wants to know is arthritis dangerous? I will tell you, no, arthritis is not dangerous. It is part of the normal aging process. You can blame your parents somewhat. We know that arthritis is partially hereditary, meaning if your parents had knee arthritis or hip arthritis, chances are you'll get arthritis at about the same age as well. A lot of people ask me if they should scale back their activities or if they should avoid exercising or walking long distances because they're worried about making it worse. And I love comparing arthritis to wearing down your tires, right? Over time, we wear the treads off of our tire and eventually they become smooth like this picture here. But unlike tires, it's not dangerous to drive on them, right? You can continue to walk on an arthritic knee and you don't have to worry about anything breaking or dramatically worsening your arthritis. It will just hurt a little bit more. And the analogy that I always give people is your knee is like a sports car. You wouldn't leave it in the garage just because you're worried about wearing down the tires a little bit. You should drive that thing, okay? Now, a couple of things that we can do to manage your symptoms before we're talking about any kind of surgery or anything like that. And the most important thing that I can give people is some kind of anti-inflammatory. The best type of anti-inflammatories are medications that fall into NSAIDs, right? The most common are ibuprofen, which is Advil, or naproxen, which is Aleve. You can buy both of those over the counter. I prefer a prescription strength one called meloxicam. You just have to take it once a day. It's $2 for a 1 month supply, and it's much easier on your stomach. But there are also options like diclofenac that are once a day. And diclofenac also comes in a gel. You may have heard of it. It's called Voltaren. This can be really helpful for people who can't take NSAIDs because they either have stomach problems or they have kidney issues and they're not allowed to take these medications by mouth. So sometimes the Voltaren gel just on top of the knee can be very helpful in those situations. Voltaren is generic now. You can buy it over the counter, but I still like to give people a prescription for it. Sometimes saves you a few dollars at the pharmacy. After medications, sometimes I send people to do a knee strengthening program. This can either be done at physical therapy or you can just do it at home. There's some knee exercises that I'll talk about on the next slide that I recommend for people. Cortisone injections are also an option. It works the same way as those NSAID medications do. They're anti-inflammatory, but instead of putting it just on the outside of the knee, we inject the steroid directly into the knee, and it reduces the inflammation and reduces your pain. These can last for anywhere between 3 and 6 months for most people, but they're not always the right option for people. I don't think it's necessary that everybody with arthritis gets injections, but they can be very helpful in delaying surgery or managing pain in patients who either don't want surgery or can't have surgery for some reason. The last thing is weight loss. Weight loss can be great. Even losing 5 pounds can take a lot of pressure off your knee, especially in situations like stairs or getting up from low-seated positions. It does make a big difference. Now, I talked a little bit about those exercises. There's a great website that was made by our academy, the American Association of Hip and Knee Surgeons, or AAHKS. It's called hipkneeinfo.org. I print exercises off for patients directly from this website. They have a great packet of exercises that you can do, and they also have some accompanying videos and lots of other helpful information about hip and knee arthritis and hip and knee patients. So we will try to include that at the end as well. I think I have it on the final slide if you want to write it down, but I think this is a really great patient resource. You may have also heard about other kinds of injections. Some people call them gel shots or chicken fat shots, lubricant shots. These are all injections of hyaluronic acid or viscosupplementation. And the idea behind these is that they allow for better lubrication between the bones when the cartilage has worn out. We don't have very strong evidence that these work, but I have patients who really feel that they make a difference, and I don't have any problem giving those injections if they've worked for patients in the past. I just don't normally recommend them for all of my patients. I would caution everyone on the webinar tonight to stay away from stem cell injections or any other type of injections that are not covered by your insurance. There are lots of snake oil salesmen out there, and while I am all for trying anything that might help you, just because I'm not giving it does not mean I'm against it, but they tend to be very, very expensive, and we do not have any evidence that they work. I think there are people who are trying to take advantage of patients and want to sell you something very expensive. The final thing that nobody wants to hear is using some type of walking assist. And when I say that, most people think of a cane, and this is what they picture. They don't want to be seen as an old person with a cane, but there are lots of different types of walking assists. The most common thing that I see is a walking stick. I had a couple patients come in my clinic with something like this today. They look very nice, they're very comfortable, and I think they're better than a cane because you don't need to bend over necessarily to hold them. I also recommend people, especially when they have arthritis in both knees, to get trekking poles or hiking poles. You can buy these at just about any store that sells sporting goods or outdoor goods. These are really, really great to get further without having pain. And I was recently in Ireland just a couple of weeks ago, and I took this photo of some really fancy canes at their Natural History Museum to show to everyone at the webinar because I think there's a lot of stigma around canes or walking poles and things like that, and really should not be. People see a cane as a device that labels them as disabled, But using a walking stick or a cane or hiking poles enables you to walk much further without pain. And most people that I convinced to start using them are very, very happy that they did. All right. So we've done all of the easy things and you're still having pain. When is it time to consider a knee replacement? And I will tell you that my most important question that I ask patients is, how does the grocery store sound to you? And if you think of Meijer as a scary place, then it might be time to start considering a knee replacement. If you're having pain every day that is preventing you from doing the things that you like to do, you have tried all of the things that we talked about on the previous slides, and you're having pain even just getting through the grocery store, then a knee replacement might be the right thing for you. I think when people start being able to walk less than 30 minutes or are really relying on a grocery cart just to get through the store, they're cutting aisles, they're leaving things behind because they just need to get somewhere where they can sit down. Their life is being really impacted by their pain. And a knee replacement is a very extremely predictable and successful operation that I think it's worth having a conversation about. The only other time that I recommend knee replacement to people, maybe before they're having that much pain, is if their knee is getting really crooked as a result of their arthritis. And it might be time to do a knee replacement before it becomes too late to make it straight again. So, to talk a little bit about knee arthritis, or sorry, knee replacement, another name for that is an arthroplasty. And you can see in these pictures here, when you have worn down cartilage on the end of the bone, what we do is we cut off that cartilage surface on both sides. We replace it with a metal cap and we put a plastic liner in between. A knee replacement pretty much works exactly like your old knee does, but it feels a little bit different. It's not quite the same, but we've gotten pretty close at this point. There are other surgeries like a knee scope or arthroscopy, osteotomies where we make cuts in the bone and then put them back together or do cartilage transfers. Those are very, very, very rarely indicated in patients with arthritis nowadays. Some people may have talked to you about a total versus a partial knee replacement, and I will tell you that both are good options as long as they're done in the correct way. A partial knee replacement might be an option if you only have arthritis on one side of your knee. They can help people get back to higher activity levels. It might be good for younger patients, but it also may need to be redone down the road if you get arthritis on the other side of your knee. So let your surgeon help you decide on what's the right uh, type of knee replacement for you. Now, there can be reasons to not have surgery or delay your surgery. If you have ongoing health concerns that maybe make surgery a little bit more risky, you don't have a support system at home that can help you afterwards, or maybe we don't have the right diagnosis yet, and we're not sure that arthritis is what's really causing your pain. It's important to not feel pressured into surgery, especially if you don't feel ready. I want patients to talk me into doing surgery on them, not the other way around. So, you've done all those things and you think you're ready for a knee replacement. Let's talk a little bit about what that process looks like. After we've made that decision, we'll send you over to the SOS clinic. They're our pre-op clinic at Trinity Health, and this is one of my favorite parts about working at this hospital. I personally think that the pre-op clinic as part of SOS does such a fantastic job. They are very, very, very interested in keeping surgery safe and making sure that our patients have the best possible outcomes. I just met with them today to update our joint book to make sure that our education, the information that we're giving patients, is as good as we can get it. We'll update your blood work and possibly your x-rays depending on the last time they were done. We also require that you quit smoking and have your diabetes under control to prevent infection after knee replacement. On the day of surgery, this is a very smooth process. Your only job is to show up, sit back, and relax. You get to take a free nap on the anesthesia department. Afterwards, you'll be up and walking on the day of surgery. Most patients are going home the same day as well. I think the most common comment that I get on the day of surgery is that people said, I thought this was going to be a lot worse. And they're surprised at how little pain they have. Hips typically almost have no pain after surgery, which really surprises me. And knee replacements really don't do that much worse. I think most people are off the heavy pain medications within a couple of days. So all you need to do is come and be ready to have it done. Now, what does recovery look like afterwards? Well, I make everybody use a walker for 2 weeks after surgery, and that's just to prevent a fall while you're getting used to your new knee replacement. You go to physical therapy for 6 weeks afterwards, and that's to get all of your motion back. It's very important after a knee replacement to work on that motion so that it doesn't get stiff. People are back to desk jobs typically around 4 weeks, and people who do labor intensive jobs, work in factories or outdoors, by about 8 to 10 weeks. At the 3 month mark, your knee is fully healed. You may just have a little bit of strengthening left to do, but otherwise, you're back to everything you were doing beforehand. I have a couple common questions about knee replacements that I answer a lot in clinic that I think are important for everybody to know. Most people ask, what's it made out of? And there are different types of knee replacements made by different companies that have slightly different metal configurations. But for the most part, the top part of the knee replacement, the femur, is made out of a cobalt and chromium alloy. The plastic liner in between is made out of polyethylene, and the tibial component is made out of titanium. And the reason that I bring this up first is that these materials have advanced quite a bit over the last even 10 years, but really over the last 40 years. People think of hip and knee replacement as something that's been around for a long time, but we were really not doing successful hip and knee replacements until the 80s. And the problem with hip and knee replacements back in the day is that they would eventually wear out. So the second most common question I get is, how long does it last? And the advancements that we've made in the materials over the last couple decades have really changed that answer. Most patients can now expect their knee to last their entire life, even if they have it done at a pretty young age. And the reason for that is the plastic liner that we put in there used to wear out, just like your cartilage does. But nowadays, the plastic liner we think lasts forever. We've been using a new type of material since the early 2000s. First one was put in 1999, so it's now about 26 years old. And as far as we know, it's going to last forever. Every 5 years, we just tell people they last 5 years longer. The other problem that we used to have with knee replacements is the metal would wiggle its way off the bone over time. And that still happens sometimes, but it's pretty rare, and it's certainly not going to happen to everybody. Now, what can I do with a knee replacement? Well, every surgeon is a little bit different, but most of us have decided that there are no restrictions on your activity. Impact activities are okay, but some people just don't like the way that it feels to do impact activities. This is not my patient, unfortunately. This is a patient from Mayo Clinic, but she does a lot of campaigning about knee replacement. I think she has run something like 6 marathons on her knee replacements since she's had it done. There are kind of more athletes doing things with partial knee replacements, and we talked about that a little bit earlier. But Jen here has total knee replacements, and she is loving them. What I will say is that most people say that kneeling is very uncomfortable on a knee replacement, or getting up from kneeling can be uncomfortable, but that's usually remedied with just one of these foam cushions, either for people who garden quite a bit or people who find themselves kneeling doing house projects and things like that. Now, why is knee replacement so much better nowadays? And this is a question that I ask myself because even in my training, I saw patients spending 3 or 4 nights in the hospital, patients being on pain medications for a long period of time, patients just not really enjoying a knee replacement so much. And like I mentioned, the change in the implant design has gotten a lot better. The new liner geometries have made a knee feel more like a natural knee. We've also gotten better at doing surgery quickly and doing surgery more precisely. But I think the most important thing is we've gotten much better at controlling pain after surgery. And that's not with narcotic pain medication. That's with long-acting injections around the knee. That's with different kinds of medications that work together. And that's with making sure that we're getting people appropriately rehabilitated afterwards to reduce the pain they have. And all of those things have really just been a big game changer into getting patients to go home the same day from surgery and be happy with their knee replacements. This is not the same surgery that it was 10 years ago. it is really not the same surgery that it was even 5 years ago before COVID. Some people may have also heard about the robot. I think the robot is a fantastic tool, but it's not necessary for a good knee replacement. Some patients want the robot. We have a robot. I use it sometimes. Dr. Steelman uses it quite a bit. I use it for certain situations where traditional instruments just don't work based on the patient's anatomy, if they've had a surgery before, or if they have pre-existing hardware in there. Talk to your surgeon about this. It makes no difference in your final outcome whether or not you have the robot done. Some of us just like to use it because it's a good tool to put a knee replacement in with. Now, when to make an appointment for your knee? I would say come and see me anytime you would like. I'm more than happy to help you find out what's causing your pain. If you want to maximize non-surgical options for your knee pain, I'm happy to give you everything that we have prior to talking about surgery. Or if you have arthritis that you already know about and you have everyday pain and would like to talk about a replacement, I'm more than happy to do that as well. So feel free to give us a call anytime if we can help you. And I've included that link again below, hipkneeinfo.org. That will take you to the patient-facing site for the American Association of Hip and Knee Surgeons. I think there's a lot of very good information on there. I think I've come in pretty early on time here, but I would love to answer any questions if they're out there and cover anything that I missed.
Yes, thank you so much. And we are perfect on time. So we will transition to the Q&A. If you have not had a chance to already, you are welcome to use the Q&A feature located at the bottom of your screen. And we do already have a few questions that we have gotten here in the webinar as well as via email. So I will get to those. The first one, and I think some of these you may have touched on and already answered, but it says, do cortisone injections break down bone?
That's a great question, and I think there's still some debate about that within our community, but the consensus is based on our literature that cortisone injections are not dangerous. They do not soften the bone, they do not break down the bone, but historically there was some concern that patients who got repeated injections for years and years and years would have softer bone when it came time to do a knee replacement. And I have not found that to be the case, and that is not supported by any of the literature. So I think cortisone injections are perfectly safe for both hips and knees.
Thank you. And I apologize if I mispronounced this product name. What do you think about Durolane injections? Do they work?
Durolane is a type of gel injection, like we talked about. It's one of the hyaluronic acid injections. Now, I personally think that the gel injections are kind of a touchy topic for me to talk about because I believe in the literature that we use to study things, and I kind of believe in the recommendations that are put forth by both the American Academy of Orthopedic Surgeons and the American Association of Hip and Knee Surgeons. Both of those organizations and the literature that we have say that those types of injections do not provide good relief. But that being said, I have patients who have gotten those injections from other providers, and they say that their knee feels great after they get it done. I do not necessarily feel that we know everything when it comes to hip and knee arthritis. There are some things that we just haven't quite learned yet. So there may be some people who benefit from those, and I think it's reasonable to try them if you're really trying to avoid surgery. But I don't typically recommend shots like Durolane to all of my patients because I don't think it's a reliable enough treatment for everyone to have to undergo it.
Thank you. And then we actually have two very similar questions. So I'm going to kind of combine them into one. The first part is that this person had surgery on their meniscus several years ago, and they now have arthritis. They're wondering if that was caused by that. The second person has a torn meniscus and is wondering if that could lead to or be worsened with arthritis.
Both great questions. And this is something that I should have addressed a little bit more in some of my other slides. Now, people with prior knee surgeries, especially an old ACL surgery, are at higher risk of getting arthritis earlier. The way the meniscus works, and I think maybe if I can go back in my slides and show a picture of it, that might help. But the meniscus works by sort of providing a cushion for the knee inside. And what that cushion does, let's see if I can go back here, is it centers the cartilage so that it glides smoother. And when it does that, it delays that arthritis. So when you have a meniscus tear, whether or not it was repaired or whether or not it was removed, it causes that arthritis to advance quicker. Let's see, here's a great picture of it. So that blue disc on either side of the knee is the meniscus. And if that's torn or damaged or removed partly, you'll tend to get arthritis quicker. And same thing with the ACL. Even a perfectly done ACL reconstruction, patients are likely to get arthritis about 20 or 25 years down the road. That's pretty typical. And I would say if you had a knee scope done or had a meniscectomy done 20 years ago and you're just now getting arthritis, that's a fantastic amount of time to have gotten out of that surgery. People ask a lot of times, well, do I have a meniscus tear? And is that what's causing my pain? Or is my arthritis making my meniscus tear worse? And I would say yes, partly to both of those. When people have arthritis, if you look at that right picture there, you can see that there's a lot of just rough surfaces, almost like potholes on the bone. And that creates a surface that's kind of like sandpaper. And when it rubs on the meniscus, it creates little tears. And I like to do this for my patients when they come to clinic, where I show them what a meniscus tear looks like in a college athlete, where it tears like that. Tears in knee arthritis patients are called degenerative tears. And these tears are little frays. They're like just little bits like that, but they hurt. They're like a hangnail, right? Every time you move on it, every time you touch it, it hurts, even though they're small. And there's no sense in going in and shaving off those little meniscus tears because you'll just make more. Sometimes they can flare up, sometimes they can get worse, sometimes they can get a little bit better. And what I would say is people who have arthritis and a meniscus tear, we typically don't recommend a scope to do anything about that meniscus tear anymore. But you're right that the arthritis is making that meniscus tear a little bit worse over time.
Thank you. I think this may also be in that same realm. If you've had an ACL repair many years ago, does this create any complications during a knee replacement with recovery time?
That's a good question. Depending on the type of ACL reconstruction or any knee surgery that you've had before, for that matter, it can make the knee replacement a little bit more complicated. Really, all it means is that sometimes we have to go in and work around pre-existing hardware. If you have screws in your knee or staples or other types of implants that were left in, sometimes we need to go in and take those out when we do the knee replacement. And that can make your knee replacement take a little bit longer, but usually not. What I will say though is that if you've had an ACL reconstruction before, or an MCL reconstruction, or any other type of major knee surgery, it means that your knee is, I don't want to say not quite normal, but it may not be as well aligned or well balanced as a knee that hasn't had an injury like that before. So when that happens after surgery, your knee is just a little bit more prone to have stiffness. Or if you've had an MCL surgery before, it may mean that we need to give you a different type of knee replacement that can make up for your MCL being weak. And what that means is that the plastic liner that we use, I hopefully have a picture here, is just designed to see that little post in the left picture there. Sometimes we put in a liner that has a wider post, and that just makes up for your MCL so that it doesn't need to do so much work if it's not fully intact. So to answer your question, yes, having a previous ACL reconstruction, or really any knee surgery before for that matter, can make your post-operative recovery a little bit more difficult. You may need to do a little bit more work with physical therapy, and it may mean that your surgery takes a little bit longer or is a little bit more involved.
Thank you. The next one is one that we received prior to the presentation, and they're asking, what are the early signs and symptoms of knee arthritis, and would there be any lifestyle changes that could be made to slow the progression?
Very common question to ask. The earliest signs that you have knee arthritis is pain. Typically, hip arthritis will present with stiffness first, but knee arthritis, the first sign is pain. And for most people, that pain will be right on the inside part of their knee. It'll be worse with activity. So the more you walk, the more pain you'll have. It will get better when you sit down and rest. And it typically does not radiate anywhere, meaning it does not go down to your foot. It does not have numbness and tingling along with it. Some people may report like knee buckling, meaning their knee gives out on them. And sometimes that's just from their muscles not wanting to move the knee because they know it's going to hurt you. There's nothing that you can do to slow down the process of arthritis. We don't have any evidence that even running worsens arthritis significantly. So there's nothing that you can do to slow it down. And like I mentioned before, I would tell you to stay as active as possible. It's important to maintain your muscles, to maintain your motion, stay active with your knee, and don't worry about making it worse.
Thank you. Our next question is, can you get arthritis in the knee after a replacement?
After a partial replacement, yes, because arthritis is just the wearing down of the cartilage. In a full knee replacement, like you can see here on the left, the cartilage is completely removed. We've replaced the entire joint with metal and plastic, so there is no cartilage left to wear away. But in someone with a partial knee replacement, where we've only replaced one side of the knee, the cartilage on the other side of the knee can wear down and get arthritis as well. And that's when it needs to be redone to a full knee replacement.
Thank you. The next question is also somewhat of a two-part. The first part is surgery recommended if someone has swelling in their legs or neuropathy in their feet? And are there any other factors that would deter from surgery, like age?
Absolutely. I typically don't think age is a reason not to have surgery. We do hip and knee replacements on people in their 90s fairly frequently. But that being said, as you get older, your risk of having a complication goes up after a hip or a knee replacement. So I would tell people to think about those risks very carefully. And I like to have a very long discussion with people in clinic when we're talking about surgery and just let them know everything that can go wrong or might go wrong with their hip or knee replacement so they can make a good informed decision about that. Now, it's a very safe routine procedure, but that being said, some of the complications that happen that still keep me up at night a little bit are when the implant loosens off the bone, like we talked about before. It doesn't happen very often, but about 1% of cases will have that eventually. And the other problem is infection. Infection in knee replacement is a problem that we still have just not solved, no matter how good we get at keeping things clean, at optimizing people for surgery, changing the way that we do the surgery. We still see about 1% of people get an infection in their knee replacement. So we do everything that we can to optimize you beforehand. And things that increase that risk are diabetes, smoking, people with neuropathy in their legs, or people with autoimmune conditions or who are on medications that weaken their immune system. So neuropathy is not necessarily a reason not to have a knee surgery, but it can be a factor and probably something that I would talk to you about in the clinic, maybe give you extra antibiotics after surgery to do everything we can to prevent that from happening.
Thank you so much. The next question is, you mentioned that knee pain may be caused by lower back pain. Do you recommend, or a lower back issue, I'm sorry. Do you recommend coming to see you first to figure out where the pain is coming from?
Yeah, that's a great question. And this is something that I see almost every single day in clinic, where somebody maybe knows that they have a back problem and they're wondering if it's caused by their hip or knee instead, or maybe they think it's coming from their hip and knee, and I think it might be coming from their back. Now, for a knee, it's a much easier way to figure that out. A lot of times, I'll just give people an injection into their knee, and we see what happens. If all of their pain goes away, then I know it's coming from their knee. If none of their pain goes away, then I may refer you to go see somebody about your back. And I have a good relationship with some of our physical medicine and rehab doctors in town They do a very good job of working up those things, and they can also give you injections to help figure that out too. There's some at Mary Free Bed, but we also have PM&R docs at Trinity as well. I like sending people to non-surgeons, and that's coming from me as a surgeon because I think they're very good at figuring out what's wrong and offering you things that are good fixes that aren't necessarily surgery. Sending you to a spine surgeon, sometimes you're in and out of the office and you don't necessarily have all the answers that you need.
Thank you. Our next question is, can both knees be done together?
Great question. We used to do simultaneous hip replacements and simultaneous knee replacements. But the problem with doing both knees at the same time or during the same surgery is that your body has to divert resources to heal two separate surgeries. And I want to make sure that you heal up your knee replacement 100% and not heal up two knee replacements 80%. So that is not something that we as a specialty are doing much anymore. All of the literature now tells us that that's a little bit more risky, but there are some patients who that is a reasonable option for. And those patients are typically people who have bad knee flexion contractures, meaning their knee doesn't go all the way straight anymore. Doing both their knees at the same time can help get rid of that, or doing them one at a time typically causes problems. Or patients who maybe have a complicated social situation and doing them both under the same anesthetic event is a better solution for them. So, the short answer to that is no, I typically don't do that, but there are very special exceptions to it.
Thank you. What are your thoughts on offloader brace for activity if you are bone on bone?
Yeah, the offloader brace was kind of designed to take pressure off the inside part of the knee and shift it to the outside part. And again, this is a great slide to have up because you can see right here on the right picture, if you just have arthritis on the side that's replaced, but we use a brace to sort of shift the weight over to the part that still has cartilage, then you can get further on that knee without having pain. I find that the patients who are indicated for a knee offloader brace, meaning they only have arthritis on one side and they have enough play inside of their knee that the brace will work, are pretty slim. And most people really don't enjoy wearing it. It's certainly an option, and I'm always happy to talk to people about it, but I don't see patients very frequently who are a good candidate for a knee offloader brace.
Thank you. How many times can you get a cortisone injection shot before it's time to get a knee replacement?
That is a very good question. I would say that cortisone shots are not necessary for a knee replacement. I don't typically recommend them to all of my patients just because they have pain, but there are some people who do great with the injections for long periods of time. Really, it's a matter of when the injections stop working for you or you are ready to have a more permanent solution to your pain than just coming in for injections every 3 months. And certainly, if the injections last 6 months every time you get them and you're perfectly happy doing that, then I would say you can get them forever. There is nothing that limits you from getting injections for as long as you would like. But if they're only lasting 2 months for you and I'm seeing you every 90 days to give you injections, and that month that you have in between is really agony, I may talk to you a little bit more about doing something about this rather than living with it the way that it is. There are some patients that really just want to avoid surgery at all costs, though, and even 2 months of relief is great for them. So I think that's a perfectly reasonable option and one that you should have the ability to make for yourself.
Thank you. Can you review how successful partial replacements are?
Uh, Good question. I guess there are lots of ways to define success in terms of an arthroplasty. For partial knee replacement, as far as outcomes go, are people happy with their partial knee replacement? People are typically happier with a partial knee replacement than they are with a total knee replacement. And the reason for that is that it feels more like your normal knee. You can see in this picture that we keep your ACL and usually your PCL for both a total and a partial, but your ACL stays for a partial too. And this makes it just feel a little bit more like a normal knee. So I think people are typically happier with a partial knee replacement, but almost everybody is very happy with a total knee replacement too. So I don't think the difference is very noticeable. But that being said, another outcome for a knee replacement is, does it need to be redone? And partial knee replacements need to be redone at a much higher rate than total knee replacements. Really, if no other reason, just because you are likely to develop arthritis in the rest of your knee and need a conversion to a total knee replacement later. So the outcomes are fantastic after partial knee replacement, but they do need to be redone more often than a full knee replacement.
Thank you very much. What is the difference between arthritis and tendonitis?
So arthritis means that you have wearing away of the cartilage, and that wearing away of the cartilage on the bone is causing inflammation of the joint. Itis is usually inflammation, and arthro refers to the joint. So inflammation of the joint. Whereas tendonitis is inflammation of a tendon. And I'll show you a little bit if I have a picture of what a tendon that we most commonly see get inflamed is. If I can find my mouse again. Um, the patellar tendon, which is the one right below the kneecap, is kind of the most common to have tendonitis in, but people in hips can also get tendonitis on the outside. Here's a great picture of an inflamed patellar tendon. The treatment is typically the same for tendonitis. It's anti-inflammatories, some physical therapy, and rest. But that being said, when you have tendonitis, we do not fix that with a knee replacement because we're not replacing any tendons when we do that. We're only replacing the ends of the bone. So a knee replacement is a great option for arthritis, but for tendonitis or bursitis, it typically doesn't address those problems.
Thank you. The next one is cortisone the same as a steroid?
Yes, cortisone is a type of steroid. I typically use triamcinolone or Kenalog when I give my injections, but there are many, many different types of steroids that we inject into knees and hips and things like that. So a cortisone is the same thing as a corticosteroid or steroid injection.
Thank you. Next one is a question just asking you to confirm, is the ACL removed for a full knee replacement?
Yes. There were some knee replacement designs that we previously used that no longer are used that kept the ACL, but we did not have better outcomes with those. Pretty much all modern implants remove the ACL now. The PCL typically stays, though.
Thank you. And that looks like it was our last question. It looks like there's several comments of thank you and wonderful presentation. But I think we've got all the questions. So unless there's anybody that wants to quickly drop one in there, I think that wraps them all up.
Well, wonderful.
So
Thank you everyone for coming tonight, and I really hope that you were able to take something away from this. I'm always more than happy to see you in the office if you have further questions. Please reach out to us if you have pain, or talk to your primary care doctor and see if seeing an orthopedic surgeon would be right for you.
thank you so much, Dr. Cross, and thank you so much to everybody that joined us. We hope you have an excellent night.
Thank you, everyone. Have a good night.